we are going to be sending out all the slides and the recording via email. So you'll get all of those details after the presentation. You'll automatically be put onto mute, but you please do put your hand up if you want to contribute, or pop it in the chat and we can collate all those as we go through. So I think next we're going to hear from Steph, and we've got a couple of really good news stories to go through. So I'll hand over to Steph so she can take you through the next section.
No.
Hi there. Lovely to see you all. Apologies if there's any background noise coming through my headphones. So I just wanted to first share a really positive story around the lung cancer screening programme, which I'm sure most of you will be familiar with. But last month, or nationally, 10,000 cancers were diagnosed through the lung cancer screening programme since it started in 2019. Excuse me, over 75% of those were diagnosed at an early stage, which is just an extraordinarily positive story. And so we've built on that locally and looked at our data. And actually, since our programme started across the Thames Valley region, excuse me, we've had over 169 cancers diagnosed, and most of those again are edging towards that 75% target, which we're all aiming for, which again is just wonderful. So we've shared this with our local press outlets recently. There's been lots of interest, particularly from BBC Oxfordshire. So there's some filming going to be taking place in the next week or so, which will be promoted locally. I've just popped in at the bottom our website. So if, because of the interest in this story, you have patients that might come and raise questions about it, do signpost them to our website. That will take them to their local provider. So it may be that they aren't eligible for their screening yet, or that it's not available in their area, but they can contact the provider directly through the contact details on that page. I will stop there and hand over to KK, who's got a similar good news story.
Yeah, hi everyone. This is about the pancreatic primary care case finding pilot, which 5 of our PCNs are participating in. And so far, nationally, across 10 PCNs, searches have produced 14,568 eligible patients. And within Thames Valley alone, we have over 1,300. And so far, 7 pancreatic cancers have been found, and other cancers found are 13, which means I would say the pilot is progressing very well. Thanks to all the PCNs participating. It's been a lot of hard work, but yeah, we're still going strong. Thank you.
I suppose now is quite a good time to pause to see if anyone's got any questions about either of those 2 good news stories across the Thames Valley. I don't know whether you've seen patients or been involved with patients that have had an early lung cancer diagnosed thanks to the lung cancer screening programme. If not, we can move on to the next PCN funded project. So I think Dr. Hetty Ranchetta is here, and it would be great if you could talk us through what the Chalfonts PCN has done, and we will go from there.
Thank you. Yeah, I'll try and share my screen, so bear with me if that's all right.
No problem.
Here we go. Hopefully, bear with me. Let's have a little look. 2 seconds.
No problem.
Too many screens open, that's the problem. So hopefully you can see this, I'm hoping.
Yeah, we can see that. Yeah. Thank you. Yeah, thank you so much.
So yeah, thank you for that introduction, and thank you for inviting me to give a little bit of a talk on one of the cancer projects that we did here across Chalfonts PCN. So my name's Dr. Ran Hetty. I'm one of the GP partners in one of the practices at Chalfonts in the Misbourne practice, and I'm the clinical director of Chalfonts PCN. So effectively, the project we looked at, which was funded by Thames Valley, And the focus areas that we wanted to do was to obviously try and improve cervical HPV vaccination uptake, and obviously improve cervical cancer. We also looked at breast screening uptake, and particularly focusing on the non-responders. And as part of the project, we also just looked at the data for the smear screening, which, as we all know, is anyway driven by QOF in-house at each practice. So these are our three practices: the Misbourne practice, the Allen practice, and the Hall practice, which make up Chalfont's PCN. We're about 30,000 population across the PCN and across the three practices. The timeline for the project was over 6 months, from the end of last year in October till March this year. And as I said, it was funded by Thames Valley for us to be able to do this project. We kind of use the approach that we're going to be looking at our data. We're going to look at the data. We're going to target certain populations in each of these focus areas, and obviously use each of our medical platforms, particularly EMIS, which we use across the three practices, and obviously get involved with the child health and immunization services, the CHIS service, as well as look at getting involved with the breast screening service to try and validate our data. We also have a PCN lay representative who is a volunteer who has been with us for the last 2 years, who's fantastic at kind of promoting these type of projects and letting people know about the things that are quite important. So just a quick slide to obviously try and say why this project, and generally why such things are quite important in terms of cancer prevention. 10,000 lives are saved yearly by NHS screening, and the national cervical screening uptake is 68% at the moment, with aiming for an 80% target. Breast screening also, it's only at 62%, and we want to aim for a 70% target, and obviously try and aim for 87% reduction in cervical disease. So one of the PCN DES requirements is to try and reduce inequalities to support cancer diagnosis and so on. So these are the real reasons for try and allow us to do it. And the idea behind the government is to try and eliminate cervical cancer by 2040 as well. And HPV vaccination is really the key way to try and do that. So what did we do? So what we did was, across the three practices, we did some baseline searches on our medical records on EMIS, and then we used that to try and validate whether the data, particularly for the HPV uptake, correlates well with the CHIS. So we wanted to validate our data. And then we also ran searches for the breast screening and see how much people who haven't attended for breast screening, whether that actually corresponds with the non-responders across the breast screening service. So effectively, what we wanted to do is to try and combine our data with their data, so that actually we are calling the right people, so kind of a list for a targeted recall. So we, following our kind of data validation and looking across the two platforms, our platform and the various screening platforms, we did a large scale HPV data cleansing. So 688 records were updated PCN wide. So effectively, our records weren't as accurate as what was live on the CHIS data. We then, for part of the HPV, because the CHIS supports kind of the school-age children, we allowed them to continue with their program, and we focused mostly on the 17 to 24 cohorts for the HPV vaccination, because they're the people who are essentially going to uni and outside of school. We piloted a nurse-led Saturday morning catch-up clinic at my practice in January of this year. I'll share the data with you in a second. And the way we really try and outreach, particularly with lots of kind of digital tools now available on the NHS, we used self-booking links and hope that teenagers in this age group would be able to obviously be tech savvy and use these to book in for the Saturday morning clinic. So that's just a quick run through with HPV. Then with the breast screening, we identified 344 patients who were overdue for screening across the PCN, and that's patients who've not had a breast screening in the last 3 years. What we then did was we really wanted to drill down on this and see who would be the best people to target to try and entice them for the breast screening. So we validated our data with the breast screening team, and we looked for the people who've actually DNA'd twice, or who've been invited twice, and we just targeted that group. And just alone in our practice, we had 92 patients who were invited twice but failed to attend. So we focused on them, we sent them text messages, and we also we tried to do as much telephone re-invitation of these people across the 3 practices for each of the groups. So, and just as an early evidence, it's very hard to kind of entice how effective that was in that short period of time. But just on my practice alone, the screening were able to tell that there were 13 further bookings of those particular 92 patients, which is good, which is great. So engagement and education, as I said, we have a PCN lay rep who was basically promoting and putting out all the stops and all the leaflets in the local places like the leisure centres and so on. We also did some social media campaigns on our websites and so on, and we tried to align that, particularly for the HPV side of things, with the Cervical Cancer Prevention Week. We also spent an afternoon across the PCN and across the 3 practices focusing on educating our staff, both admin and clinicians, about the importance of obviously cancer screening and really trying to make every contact count, the MEC approach. So really kind of embed that into appointments going forward. And we obviously submitted our reports on a monthly basis. Just very quickly, the data. So as I said, HPV vaccinations. So we had 688 records which were updated. 168 patients at my practice were retrospectively confirmed that actually were vaccinated across by CHIS. So the data was really inaccurate on our part, but also kind of highlighted the importance of better communication across the 2 services. And out of them, we identified 59 patients at my practice between the ages of 17 to 19 and 106 between the ages of 20 to 24 who haven't been vaccinated. And that was the pilot that we did in January. Unfortunately, we had 45 slots for the nurses, and only 21 were taken up or booked in. And out of those 21, sadly, only 1 turned up. So actually, the learning from this one was that a standalone clinic wasn't probably as effective as what we'd hoped it would have been. Now, there's a caveat to that. It was a January, it's post-Christmas, it's a Saturday morning, but we tried to pick the people, try to pick a holiday when they're more likely to be around and try to grab a Saturday when it's more likely to happen as well. Sadly, it wasn't in our favor. Because we were the pilot, we obviously fed that back to the other 3 practices. They were given what the outcome from our pilot with running a standalone clinic. The other practice didn't really pursue that, and it was decided that it's better to try and entice them ad hoc when we realize through their immunization screenings if they're coming in for something else, particularly in that age group. The breast screening I've already kind of mentioned, particularly focusing on my practice, that out of the 344 across the PCN, 92 were through 2 DNAs and 13 hopefully were subsequently booked up for breast screening. Just a little comparison on the cervical screening, as I mentioned earlier on, that's driven by QOF. Not much of a huge difference between the comparisons for the period during our project versus the same period the year before, but that just shows consistency in how we're all doing well in our kind of cervical screening. So key achievements, I think the biggest thing was the major HPV data cleansing, as I said, across all 3 practices. So all our records are now being updated. We've made contact with CHIS. We've got logins now for various people at each of the practices for CHIS, which allows for live data to be fed through, making our lives a lot easier, particularly for our nurses. We did do a HPV catch-up clinic, which was sadly not as effective as we wanted it to be, but at least it was a trial. The workforce education was probably a big achievement. Our admin staff are pretty clued up, especially with trying to reinforce screening promotion and obviously addressing patient barriers. And I think a lot of us are a little bit more clued up. And, if we get a teenage person, ask them, have you had your HPV? If not, go and find out and let us know. And I think I think the key thing was also trying to find the right people, particularly with the breast screening, identifying the ones who really have failed to attend on numerous occasions was far better than sending a wide mass text. So yeah, PCN wide learning as well in terms of coding was a big thing. We identified significant variation in how practices recorded their breast screening, from DNA to declined to opting out status. And across the three practices, we now have created a blanket coding for each of those things, and we all stick to the same thing. So we were all coding it very differently. And I think the biggest and a really important factor is that we've actually strengthened our partnerships across the chairs and across the breast screening teams. And they have obviously promised to kind of touch base with us in a few months' time as well, just to re-look at the data and see if our campaign made any difference. So that's really good, and obviously a good relationship with Cancer Alliance as well. Challenges, some of them I've already highlighted. Low HPV clinic uptake in the teenage group and high DNA rates, particularly for standalone. I think the reporting lag from screening services, obviously that has an impact on the measures in the project. The coded data versus document-based records. So actually, our coded information was very different, but that obviously has now improved. And the retrospective data cleansing altered the baseline, so which means kind of complicated direct comparison to pre and post project as well. And I think the persistent non-responders, short-term outreach alone was insufficient for particularly those teenage hard to reach groups. I think the lessons learned, data quality is the biggest thing, and investing in validation before outreach is far more important. Targeting the right group of people rather than the blanket population messaging. And I think we're now all embedding our vaccination and screening into routine care, not just standalone clinics. Probably are not the best way forward. I think it's something we've learned. I think allowing longer evaluation windows, so we're hopefully going to meet up with screening again just to really see what the next few months will bring, not just the weeks. And just coding, I think we're really far better on our coding now, particularly for breast screening, but for the DNA and the decline versus the opt-out. We were doing all very different codes, so we're all now consistent. So the next steps, I think we are going to kind of maintain as a PCN regular HPV and breast screening data cleansing exercises. We've decided to kind of revisit this in about the next 3 to 6 months towards the kind of autumn time to see how we're doing. Embedding kind of, standardizing PCN coding, as I said, is really important, which we've done. Embedding into routine care, so kind of moving away from ad hoc clinics and really encouraging screening checks in every appointment, nursing and doctors, any clinician really. We've kind of educated our staff across the three practices, continue to build on the partnerships and the links that we've already done. And I think, focusing on that cohort, 17 to 22, 24s for the opportunistic vaccination rather than really just doing standalone clinics. And hopefully sharing this learning widely, I think, of what we found was useful versus what wasn't so useful. So I think the project, really kind of was the stepping ground for change, really. There was a short-term increase in screening uptake, but this was limited, but the project delivered hopefully significant long-term value. As I said, the data cleansing was probably a big achievement for us. Really kind of working on the DNAs, particularly with the HPV vaccination groups and the breast screening. Key learning, data quality, coding consistency, just really routinely integrating into our clinics to try and promote these things. And hopefully we are better positioned to try and improve our cancer diagnosis across our population. That's it really. If there's any questions, please feel free.
Thank you, Ran. It's such a great piece of work and so many different achievements and outcomes within it. So thank you for sharing that. I'm sure it's really useful to lots of people. I'm not sure if there's any question. I've got one before people start. It was on the data cleansing side of things. Yep. How did you initiate those kind of collaborations with the different teams that were enabled, like CHIS and the breast screening? Could you talk us through that? Because that sounds like a really useful thing to do, but maybe something you did proactively.
That's a really good question, and I think we have Thames Valley Cancer Alliance to thank for that. We had Gloria and KK who were supporting us with that. So they actually got us in touch with the screening teams, and subsequently we then got in. We were signposted to the CHIS nursing lead, who individually went to the 3 practices. We had a meeting, and then we obviously got set up to have access to that. There was training that was needed for an hour for each of the individuals who needed access. So we've done that for our nurse, for our QOF lead, and for our ops manager. So it didn't take long at all. It was a half an hour meeting, and there was a little bit of IT work behind the scenes to really make that happen. But it's an invaluable tool now. In fact, I was just talking to my nurse about it last week, and she goes, it's made her life so much easier.
Yeah, it sounds like it's got such a big impact. And I was just wondering about the kind of feasibility of other PCNs and practices doing it.
I would highly recommend it. I think that's the feedback, certainly, that I think all 3 practices across the PCN are now enrolled and utilizing it. So that's a big stepping point for us.
Yeah, great. That's a really a key thing to take away. And I suppose it's something that we can help with as well at the Thames. I'm sure KK and Gloria would be willing to help other surgeries if they wanted to make those connections as well. Is there any other questions at all? I can't see, sorry.
I don't see any hands, Katie.
Okay, well, we'll move on. I think if we can go back.
I believe there's a hand up, Katie.
Oh, sorry. Do you want to go ahead? Sorry.
Hi there. Thank you for this wonderful presentation. I'm Dr. Kader, one of the GPC clinical directors at New Reading PCN. Can you just explain to me why there has been a difference in data cleansing? Why are the records different from the one which CHIS has and you have? Because we seem to be experiencing the same issues, unfortunately, because we are working on a cancer project for cervical screening and breast screening. We were given 3 lists, and each time the list was different. And now we have been given a list from the hub, which seems to be more or less relating with the figures what we have in Ardent's manager. This has been a very futile exercise, although we have volunteered for this cancer project for nearly a year now. Initial months have been quite cumbersome without much result. And it has taken such a long time for us to actually things the time could have been better used, which we thought was a waste of time. So can you elaborate more? What challenges did you actually find? Did you have any such issues? What we have experienced so far, please?
That's a really good question. And just to kind of break that down, yes, I think we actually face the same challenges, and to identify that there was such a discrepancy between actually who we had vaccinated on our records versus who actually were. And I think that's the communication I think between CHIS and us, because a lot of these vaccinations are done in school, and they're done in school, they're recorded in the school platforms or the CHIS platform, but that data sadly hasn't been shared across with us. Now, CHIS is a live platform, so effectively tomorrow's data is different from today's. And we are probably in the same boat as you. We had these, and we had one staff member who literally just went through every single list of patients that we had at our practice. That's how we did it, compared it to the data that we were given by CHIS, and just really had to recode it. So it was quite cumbersome, but I think it's because of the lack of communication between the CHIS and us, because most of these vaccines are done in school areas. What we do now is we look at the CHIS platform on a regular basis and see anyone who's obviously been vaccinated in the last week or month, and then get that updated onto our records, because to expect patients to actually share that information with us is also very difficult. Sometimes the parents don't even remember if they've had the HPV vaccination or not. So I think it's just the comms between the two services.
Yeah, I mean, again, the major reason for the DNAs in various screening programs, whether it is cervical screening or breast screening, is the appointments are sent so far in advance.
Yeah.
Patients do tend to forget. I mean, I wonder if there is a better use of NHS app wherein the reminders can be sent across to the patients. Like, I mean, here, I mean, it is something which can be very easily done, isn't it? I mean, now we've been asked to do 2 telephone calls or 1 text message, which is actually because we all have got systems embedded in our system, isn't it, for cervical screening or HMN? Whereas for breast screening and others, like, this is beyond our control. Yeah,
It is.
I think
Absolutely.
it is fair, only fair for the provider, like the national one, wherein they can have systems in place, and only if you've been asked, because we received a list of about 800 patients of, like, to contact. I mean, on top of what we are doing, if you've been asked to contact 800, it's a 1600 phone calls twice, and then to send invites. That is a lot of work, isn't it? I'm not sure how you guys managed to do that. I mean, I'm sure it looks like you have done very well. Thank you for
Took time.
Thank you.
Yeah.
And just before Roxana comes in, they are trying to move some of the screening to the NHS app. So cervical screening is kind of on its way, but I think you're right. That's the best way to communicate with patients. So especially, we have to be mindful that not everybody uses it, but it's a good way of reminding people if they've set up their alerts on there. So, Roxana, did you want to say something?
Yeah, just briefly, we did a similar piece of work at Riverside where we texted out all the people who were overdue for the HPV vaccine, and we had a slightly better uptake. But we were texting out just a couple of days before, and people were booking it. If they were going to book, they did it within a couple of minutes, and we almost filled a clinic. And then they were sent reminders, but we had at least 50% DNA rate as well, even though it was literally a couple of days before.
Yeah, I think, just to know, we were actually ringing patients who had who had booked in and reminding them 48 hours before on the Thursday, and they still didn't turn up.
Yeah, it's so interesting from a behavioural point of view, isn't it? Because we've done a similar project and for cervical screening, and it was on a Saturday, and you just thought that might be more suitable, but actually the DNA rate was huge, and you just presume maybe people have, something better comes up, and it doesn't take much, does it, to tip that balance? So
I think that's
but
it.
thank you. Yeah, thank you for that. That's really great comments, and thank you, Ran. That's brilliant to hear
Pleasure.
about
Thank
the
you.
project.
Thank you again. That's really good. Thank you for inviting me.
No problem. So I think we're over to Bex now. I've seen you on the call, so it's just an update on some of the TVCA campaigns.
Get off mute. Yes. So it's just a quick run through, and I've put some links in there so you can, when this goes around, you can click on them and see more. So basically, our breast screening pilot is I can't speak. 12-week pilot. It starts kind of quite quickly in June. So this is something that that we're working with CAJA, who are a unit who work with groups of people to encourage them. So it's like behavioural science kind of look at things and how we do stuff. So they're working on this project. So they're doing a survey, focus groups and targeted communications through communities. It's specific groups that they're looking at getting in touch with. So that's people who are less likely to turn up or just not have the information suitable for them. So that's a little project that's starting now. There's another one that's only just popped up. I don't know if you know about this, Steph, but there's another one that's just popped up yesterday about HPV pilot, which is a similar kind of thing, but not similar, which is happening now. So they're not in their discovery phase. They've done their survey, and they are looking at encouraging people. Parents, we were talking about parents actually, who have got children who are in that sort of 10, 11 age group. So getting them on board with getting their kids vaccinated, their HPV vaccination, and addressing any issues that they have. So that's another little kind of side issue, but that I didn't have a chance to put that in there. But anyway, yes, I'll shut up now. Going on about that. So the community outreach program. So that's the yes, this text has changed slightly. bit confused. This is the outreach programs that we've been working on. So we've got colorectal, breast, and cervical screening on the websites, and not on the websites. This is the van. Sorry, I've just suddenly realised. So this is the van. So there is an outreach van that's going to be going to specific areas of low uptake of various screening, or they have low awareness in their areas. So this is really exciting, and Steph's going to be talking more about it and have more information on that. That is a really, really good one. So I'll just be supporting with kind of making sure that there's stuff on the vans that people can take away, so they're not just looking at it and go, well, it's nothing to do with me, that they get it in their area, they see what it's about, they see the topics that it's covering, the screenings and awareness that's on there, and they can, take something with them. That's kind of what I'll be working on with that. Lung cancer screening, which we've talked about briefly. So we've got screening leaflets and we've got leaflets about lung cancer screening and the lung nodules. So they're now on the website. I've just put them on now. And we're doing our working with BBC Oxford on this patient case study, which again we want to share with everybody so that it'll be something that's useful longer term. So it's somebody who's been through the process, how it made them feel, what drove them to go to their screening. All this kind of is this touchy-feely stuff that's really important. So it's not just about go. It's about why people go, or why they don't want to go, what their fears are and what stops them. So that's what we're kind of trying to push as well. And then the other thing, I'm looking at this now, though, recognising the head and neck cancer. So this is a fantastic video by Wyvern PCN that we funded about symptoms and signs of head and neck cancer, and what to do if people have concerns. So I've put the video link in there. So that's gone on social media, and that's doing quite well. The awareness toolkits are on the website now. We've got prostate, bowel and skin cancer coming up shortly, but there's lots on there. There's lots of information on there. So about screening and about how you can boost awareness and boost uptake in your clinics. So there's that. The inequalities web pages are now live, so we've had a little tweak of that because we've got a new website. I keep saying new website, it's 3 months old now. Does that mean it's new? Just a bit. It's a teenage website. So that's got lots of new pages on it, and the equalities web pages are now live. So there's some resources in there that you might find useful or to share. And again, we've got the Ascend framework, which Razvana manages, and that's on the new website. And there will be some more tweaking with it. There's lots of tweaking as ever. It's a website. But there'll be lots of information on there that you'll be able to read, and for staff to get development and training opportunities. So there's that. That's it from me. But if you need anything else, please email me. I should have put my email address on there. Yes, please.
Thanks, Bex. That's really useful. And I think we're going to talk more about the mobile cancer awareness next. Just to say on the toolkits as well, I think we're producing a number of those, and what hopefully they will do is provide a really good source of information, because obviously we know there's lots of information out there, but they've got professional resources, patient resources, and it's all in one place. So hopefully that's useful, and any feedback on those is really appreciated as well. So if there's things that you think may have been missed or would be useful to include, then please just let us know. So now on to the mobile cancer awareness event that we're running. I think we've got Hannah here who's going to talk us through that programme of work.
Yeah, sorry, it's Vicky. I work alongside Hannah.
Vicky.
So no, yeah, Hannah is on the call, but I'll run through the slides. So
thank you,
it's
Vicky.
great that you've got the slides. So yeah, we can just move on to the next slide. So just to give you a bit of an overview of EMS healthcare. So as I say, I'm Vicky from EMS healthcare, and our main goal is to bring medical solutions into communities so no one is left out of reach. And we do this through the use of our mobile units. So since starting in 2000 with health communication campaigns, we've grown to deliver complex national health programs, and have supported more than 95 NHS trusts, private providers and research sponsors. So we've got 3 core areas of the business, so community engagement, clinical research and clinical capacity. There is a short video on the next slide that will hopefully play, and it'll just be a lot more inspiring than kind of me talking at you. Thank you. So hopefully that's a bit of a snapshot. I've been at EMS for, gosh, 15 years now, and still trying to explain to my family what the mobile units are is hard. So hopefully those case studies have kind of stood out, and the majority of the units shown within them case studies is the unit is that going to be used on this project. So that's our outreach unit. So just a quick overview of the team. You've got Nicholas, our project coordinator, Hannah, project manager, and myself. So within EMS, though, there is a much larger team. So we've got our productions team, sites team, operations. So it's quite a big beast. And then if we just go on to, I'll share I think if I won't go through all the next 2 slides, we can kind of send them across. I know the deck will be shared, so that's fine. Time's precious. So just a couple of further deep dives into the results from the case studies from previous cancer alliances that we currently work with or have worked with. So the Greater Manchester Cancer Alliance, so this is had 4 roadshows over the last 18 months. So, and we've had over 200 events, engaging with over 30,000 people to raise awareness and educating them on the signs and symptoms. On the next slide. And then, yeah, just a couple of more breakdown. I won't go through everything, but we can share the slide. So 128% boost in people's awareness of bowel cancer from this Van Can. The number of interactions is just great, and the team that we have on site are just great. So we do work with yourselves to kind of train them up, so they won't always have a strict clinical background. It is a preference, but in terms of that engagement with people, we feel works really, really well. Then North East Cancer Alliance, that was 2 campaigns. This is pretty similar to how you guys are going to work it in terms of it's going to be 1 unit and it's split over a period. So a 12-week campaign on one and then on another. So yeah, we engaged with over 7,000, well, nearly 8,000 people on that one. And that was only over 78 events. And then, yeah, a couple of bit more deep dive into the results. So in terms of the number of reactions, there was 3,600 over 12 weeks, and there was a 90% increase in understanding of skin cancer, and over an increase of 683% of ambassador engagement. Well, so just obviously to touch base on the project that's going to be going ahead in with you guys. So it is based on 2 awareness campaigns. So focusing on creating awareness of cancer screening programs and increase awareness of campaigns. I think it's been defined a little bit more, as touched on a little bit earlier. So then we also recruit and train 2 ambassadors on the unit, and then that is with the support of someone from the GP side to obviously give that key information of what we want to get across and the key messaging. There's going to be 2 external half vehicle wraps. So as I said, the 2 campaigns will have their own key messaging, and that'll be wrapped around the vehicle, which I think we've got a couple of images further on. Yeah, expected outcomes, so improved understanding of colorectal cancer risk factors, signs and symptoms, and the breast and cervical screening programs across target population. Increase update of cancer screening programs, improve awareness and understanding of signs and symptoms of cancer within the communities, and encourage positive behaviour change, and improve outcomes for people throughout contributing the earlier diagnosis and improving survival rates, and improved engagement with access of healthcare services amongst target populations. There is a couple of KPIs in there, and again, we create a survey on board as when we interact with each participant that'll help lead into these into the KPIs. So if anyone ever has any like ideas or key questions they'd want to pull from the campaign, if you let us know early on, we can always build that into the survey, and it does add such value. I won't go through everything from in line by line. So in terms of the vehicle for this project, it is the outreach vehicle. This is absolutely fantastic for getting into the heart of communities. It's in terms of sites that we go to, we've built up great relationships with a lot of the superstores that we can get onto, but then we have a huge site database as well, so community centres, universities, things like that. This is a snapshot of the inside of your vehicle. This pretty much is the layout, but we can share the layout drawings for the exact vehicle afterwards. But yeah, that's what we've got. And then there's just a couple of snapshots of examples of the interiors that we've used on previous campaigns. That was us. Thank you.
Thank you, Vicky. That was really useful and great to know what's coming locally. I think Gloria is now going to go into a bit more detail about the timelines for that in our local area, which may be really useful for primary care if patients are coming in asking questions related to hearing or seeing something on the vans. Then it would be good to know when it's in your area and how long it's there for. So over to you, Gloria.
Thanks, Katie, and thank you, Vicky, for going through the full breadth of the project. I'm just going to touch briefly on the campaign and the scope itself. So, as Vicky mentioned previously, we'll be running two separate campaigns over a period of 12 weeks. The first one being the colorectal cancer awareness, and if you could kindly make a note of the dates, which is week commencing the 24th of August, right up until the 15th of November. The second campaign will be run from week commencing the 23rd November to the 18th of December, and I will be looking at breast and cervical screening. Due to the Christmas holidays, there will be a slight break before it reconvenes again in the new year on the 4th of January until the 28th of February. So in terms of the scope, these will be the areas we'll be covering, and also particularly focusing on adults and people aged 18 and above. The next key task that we're currently working on is the geographical locations where the vans or the unit will be visiting. So in terms of the priority areas, we are aware that socio-economic deprivation is closely linked to higher rates of obesity, as well as increased colorectal cancer risk. And we're also aware that there seems to be a reduced engagement, particularly in areas where, or in deprived areas, and people within those particular areas are less likely to potentially engage or recognize potential cancer symptoms. With this in mind, we are currently trying to prioritize areas of higher deprivation and areas where there are known increased rates of obesity. So we're drawing information from fingertips and also trying to work with key stakeholders to gather local intel to ensure that the unit reaches communities where there will be who may benefit the most from the campaign. In terms of key stakeholders, we will be engaging with yourselves as well as local charities, local authority, public health teams, to ensure that we are covering all our bases. So this is also a plea to ask if you are aware of any charities within your areas or any community engagement events within the time frame that was mentioned earlier. Please do kindly get in touch and let us know, as we would like to tag along and also ensure that the campaign is supported locally and also amplified where possible. Steph, I will bring you in briefly, if that's okay.
Yeah, although I think between you both covered it beautifully. So yeah, this is a project we're super excited about. Keen to get lots of engagement from local teams. We will update via this group and via email as we start to develop those site locations. So hoping that we'll have those agreed in the next couple of weeks. But then from then on, it would be really great to start identifying, where health professionals may want to come and use it as part of your own promotion. We've got a couple of secondary care teams as well, also interested in joining as it roves around. So yeah, just keen to keep you updated, but also keen to hear your thoughts on anything specific you would like us to cover, or if you've got any case studies that you think might be useful for us to promote as part of the service.
Thanks, Steph. Over to you, Katie.
Thank you. Thanks, Vicky, Steph and Gloria. And I think, Anna, I don't know whether you want to mention briefly about the work that you've done, because that sounds like a really amazing project and definitely something that could be integrated into this kind of public health cancer awareness work.
Yeah, thanks, Katie. I thought I'd just mention that we actually carried out a public health event in a local community hall, and we covered all the useful things we thought that would be for patients, prevention, going through signs and symptoms. We covered screening with the local trust and ICB members there. We had the bowel screening team there. So we had lots of teams, and it was a sort of 4-hour afternoon on a weekend, on a Saturday. And patients went back, I mean, they all came and shook my hand and other people's hands and wanted to take photographs and took away lots of material. And we're really quite engaged. So, I think this is another way, apart from, this van approach, which is great, some of these screening campaign approaches, but this is a local initiative, which I think would be really useful. It's a health education event, which PCNs ought to be doing and practices ought to be doing. So it was received really well. And Rachel Hinksman is on the call today as well, and she was the screening lead for our area, and she presented as well, very, very well actually. So I think it went down very well. I don't know if Rachel wants to make any comments, and I offered this to other PCNs in East Berkshire, and they've lapped it up actually, and they want to set something up locally for their populations. So it's a very interactive way we presented it. I don't know, Rachel, do you want to give Rachel 2 minutes if she's still on the call?
Yeah, of course.
Can mention. Yeah.
Hi everyone. Hi Anna. Yeah, thank you very much for that intro. Yeah, it really was a fantastic event. It absolutely showed the interest out there in information about cancer screening, signs and symptoms of cancer. You covered that beautifully, Anna, and also where to get information and support following a diagnosis. So we did cover an awful lot in those 4 hours. But I say I think to me it just showed what interest and appetite there is out there. I think Anant's been very modest about his role and the role of his PCN, but they did a fantastic job promoting it. I know they use social media, but they then did a text invite, and I understand that is where a lot of the bookings came from, and they even held a waiting list. So I think it's like understanding all those details at each stage of it, which is so useful. And yeah, it'd be great if other PCNs and practices would like to run something similar, and be really keen to help them and support them with that.
Thank you, Rachel. So Steph, do you want to come in?
Yeah, I was just going to say, actually, it'd be really great to pick up with you, Rachel and Anna, just to take some more learning about your approach and actually how we can, support anyone interested in doing something similar, but also how we can apply it to this particular project. But, just thinking about what you said with regards to, text messaging, actually, how do we promote that the vehicle is going to be in the area to make sure that we maximize uptake and engagement? So yeah, if we can pick that up separately, that would be great.
Yeah, thank you both. Right, over to KK or Steph. I'm not sure which of you is giving the update, but we're kind of right on time. So you've got about 3 minutes or so.
Yeah, that's fine. I'll start. Next slide, please, Gloria. Just to provide quick updates on some of the projects we've discussed in our last PCN meeting. So one of it was the Help Flag pathway, and we've had a lot of discussions and meetings in between before now. So we're still doing the project scoping just to confirm all the full requirements, what's going to be required, and map out the key stakeholders that we need to bring on board before the expression of interest process is started. And there's an opportunity to join the current University of Exeter pilot with an initial cohort of only 10 GP practices. I know the last time we talked about it, many of you expressed interest, but yeah, we would have to select, for starters, only 10 GP practices to get on the pilot when that time comes. So on the back of that, we've been having discussions with the University of Exeter project team and continued discussions both internally and outside with the trust to to have a shared understanding of what the project needs, delivery expectations, and the roles everyone would play. So when that is completed, all the scoping, that expression of interest to be developed and then shared with all the PCNs. For the PCN coding project, I was saying it's a very good thing Ran talked about his project at the beginning, because now you have a better understanding of what we're talking about in terms of giving the opportunity to all of you to, do that data cleansing and get paid for it on the side too. So I'll leave Steph to take on the rest of it. But just as with the Help Flag project, we've been speaking with the screening and immunizations team, and we'll have a further meeting with RAN and his PCN on, should I say, fine-tuning the requirements of that project, because we want to make sure that the expression of interest process has fully understood the instructions and everyone is able to get the objectives they want at the end of the day. I'll leave Steph to touch on the funding for that and then the self-request chest x-ray. Thank you.
Thanks, KK. Yeah, so I'll quickly just touch on the self-request and then come back to the funding side of things. So for those of you that have joined previous meetings, we've had several presentations around this initiative, which is really gathering pace and actually was featured in the cancer plan. So this is where patients with symptoms can request a chest x-ray and have that reported, and it's designed to speed up the pathway, but also to, I guess, catch the patients that aren't eligible for the lung screening pathway as well, that may not present because of numerous reasons to the GP. So with all of these projects, they're designed, I guess, to take the learning from all the projects that have been running and allow everyone an opportunity. So particularly, Ran, thinking about your project, amazing learning that came out of that. So we should be scaling these things and providing the opportunity for others to benefit from the work that's been done. Similarly with the Help Flag, this came from some, learning around platelets that had been done through previous audits. So we have budgeted some funding to be able to support practices and PCNs to participate in these projects. So once we've defined and had the approvals to take them forward, as KK said, we will be submitting applications for expression of interest. It may be that we can't do everybody in this year, but that doesn't mean that there won't be future opportunities. So I will just caveat that it depends on how much funding we've got available, but we do want to support as many PCNs and practices to participate in these projects as possible. Some of them are, I guess, for example, with the Help Flag, it will be limited to 10 GP practices because that's the requirement of the university. However, pending the results of that, it could be that we take the learning and apply it into, next year's work. And the same with the self-request chest x-ray. That will be dependent on capacity within secondary care to be able to deliver any potential additional chest x-rays. So these are almost like proof of concept projects that will then be scaled in future years if proved to be successful. I'll stop there. I think we may have a minute for questions and then AOB, Katie. Yeah. Has anyone got any questions on anything that's just been mentioned? I know the funding sometimes comes up as obviously a very important point. Does anyone have anything that they want to ask around that? I don't think I can see any hands. Katie, the bit I will just come back on that is part of the reason that we've been, I guess, I wouldn't say slow to initiate expressions of interest. It is only June, but we are really trying to understand what the financial requirements would be for each of these projects, so that we're not shortchanging anybody. I think, and we want to make sure that whether it's in primary care or secondary care, appropriate reimbursement is available to make sure that these projects are as successful as they can be. So that's part of the conversation we're having at the moment, is to really understand the ask.
Yeah, and that's crucial, isn't it, to know that it's adequately resourced for any time that's needed. And I think that's something that's been learnt before as a really important factor. Has anyone got any other business that they want to bring up or anything else they want to mention before we close off the meeting? I think I can see. Oh, Gloria and Steph.
Can I just finish up by saying welcome to all our friendly colleagues. It's lovely to have you join us. So yeah, absolutely delighted that we are having this meeting as the new Thames Valley region, or Thames Valley ICB. So yeah, welcome, and look forward to working with you all. And I must stress as well, all of the projects we've mentioned do extend to Frimley. We haven't, when we've been thinking about them, we've not kept it to Bob. It's been the full new Thames Valley ICB.
Thank you, Steph. Yes, welcome Frimley. And I suppose that just leaves me saying thank you to Ran and Vicky from ENS and the TVCA team for all the informative presentations, and then also Anant and Rachel for talking about their great event, because I think there's a lot of shared learning from there too. So as always, we'll send out the slides and the recording, and if anyone has any questions about any of the presentations, then just email in. But thank you for sparing your time. Hopefully the weather picks up for the weekend, and wishing you a good rest of the day.